And now I would give the floor to Oliver Cornely. Oliver Cornely is Professor of Internal Medicine and consultant in infectious diseases at the University Hospital of Cologne in Germany, where he is Scientific Director of the Center for Clinical Trials. He is also the past president of the European Confederation of Medical Mycology and chairs the Infectious Disease Scientific Working Group at European Hematology Association. He was recently involved in the consensus statement defining how to manage COVID-19 associated pulmonary aspergillosis, severe co-infection in the context of COVID-19. So thank you, Oliver. The floor is to you.
Thank you for your kind introduction, and for the possibility to share with you some thoughts, and from the clinician's perspective, I have to say. So don't yell at me. No molecules. We'll see. Challenges, personalized medicine, the case of Kappa, and actually, just briefly sharing my transparency declaration. It's all companies we do clinical trials for or with develop the trials. And this is Kappa. Kappa is COVID-19 associated pulmonary aspergillosis. So why that? At the very beginning, so a good year ago, we thought what might happen if there is a respiratory virus, and what we learned from influenza, we applied and we said, well, we start screening for all these patients that are intubated with pulmonary failure on our intensive care units. And actually, we found aspergillus in respiratory secretions, which is sometimes occurring, but not very frequent, with severe influenza, and influenza patients being on artificial ventilation. However, we found even more so, and we're able to propose consensus criteria as definition of what is Kappa, how do you define it, what are the diagnostics parts that you need. Another part of the background is that with aspergillosis, as with any other fungal infection, they all are neglected diseases. We don't have a lot of tests, and we need some sort of, well, we need a strategy and to collect the individual evidence that might be from histology or from microbiology lab or clinical factors and radiographic factors. Radiology is part of clinical in these usual definitions, and that is where we originated from when creating this really complex set of definitions for the disease. So it's about likelihood that there really is aspergillosis, because you can take a biopsy and prove it, unlike a tumor, for example. The second aspect, this is the lungs of the first 5 patients, 5 of 19. So we didn't do percentages because each and every patient would be a lot of percent here. And but when we later followed on all the way to August, and then in a separate analysis all the way over more than 1 year, we found a pretty solid and stable incidence of 22% of aspergillosis in these patients who were on a respirator because of COVID-19. And these lungs are diseased. I can't even show you a single piece of one of these lungs from the 5 patients where there was normal lung tissue. It was just all diseased tissue. Well, can't we just take a sample from these lungs? Not easy. There were recommendations against bronchoscopy by major scientific societies, and that is a little bit softened now, but you can see why that is. We used UV light here, and in this model, you can see what happens when we open the tube of the patient. We need to open the tube so that we can insert the bronchoscope to do the bronchoscopy and get the sample and be able to perform an inspection of the trachea and the bronchi. So what happens on panel A is that you see this little cloud here, and that's aerosol and droplets. And whatever is shiny and bright is coming out of the tube and out of the patient, or in this model, the model lung. You see the droplets flying around in every direction on panel B, and on C, that's the bronchoscope in the right hand of the physician being now inserted into the tube. Everything is full of material, everything is full of lung material, and that is likely how healthcare workers might contract infection. So that is why many of these patients were never receiving a bronchoscopy, although outside of the context of COVID-19, it would be absolutely clear that these patients need to undergo one or over days, several bronchoscopies, so that was not done. Very difficult to establish the diagnosis because we are missing the microbiological part then. That is one out of three pillars that our diagnosis or the probability of a diagnosis may rest on. So once we establish a diagnosis, then the usual treatment, that's again part of the definition paper and management recommendations that we published last year, you would usually use voriconazole for the azole sensitive on the left-hand side. And then it might be that the aspergillus that we are now after is azole resistant. So that's a completely different topic, but let's stay with one because it's already complex enough. And when we stay with the majority of the azole sensitive ones, we would usually use voriconazole for treatment with these doses, etc. And the thing is that voriconazole, which is a fantastic drug against aspergillus and other fungi, its metabolism heavily depends on the genotype of the patient, and that is specifically CYP2C19. And you can see you cannot predict the actual exposure of the patient to the drug unless you know the genotype, or it might be faster because that had a mean turnaround time of 11 days in that study. It might be faster to just do therapeutic drug monitoring, and that is what's currently being recommended in the, for example, European guideline with voriconazole therapeutic drug monitoring in any case whether you use it for treatment or prophylaxis. There's one more aspect to the drug, and that is the case with many other drugs, and practically, well, with the majority of the antifungals, we do have other drugs in the patient who prolong the QT time, so who are cardiotoxic. And that's a selection. It's an ever-expanding list of drugs. It's not meant for reading, but it's good to know that we need to refer back and check whether we have drug-drug interactions that influence voriconazole metabolism. And many of the drugs are frequently seen in these patients, like proton pump inhibitors, antibiotics, etc., etc. So we do have 4 areas that we face just clinically. It's an acute condition, so we have a huge time pressure. Whatever we want to do, we need to do very, very fast. We need to decide fast. We need to analyze the host, of course, and we heard about analyzing the host. We need to, well, first obtain the pathogen, which might be difficult, and then so that we have something to analyze the pathogen and the genetics of the pathogen, alluding into the direction of resistance of the pathogen. And then we have to evaluate drug-drug interactions, and all that under extreme time pressure. I'd say we need a lot of clinical trials to validate and to find out what exactly, how we can use the basic science and other results. And just very briefly, because this came to life a week ago, just want to share with you, this is for vaccines, Vaccelerate.eu, a newly funded network with already 220 clinical trial sites. Just that I haven't mentioned because that could be the network of sites where such studies for vaccines and others could be carried out on. And this is dedicated to Corona. Thank you very much for your attention.
Thank you very much, Oliver. Very clear talk.